The main focus of today's presentation was really showing the changing landscape in how we treat locally advanced cancers of the esophagus and the stomach with integration of immunotherapy and checkpoint inhibitors, but also maybe omitting the need of giving a radiation to these patients. So whenever you have a large randomized trial, a phase 3 trial with overall survival as the primary endpoint, and that trial is clearly positive for the primary endpoint of overall survival, but also key secondary endpoints of progression-free survival and actually increased rate of pathologic response rate, then that would be considered practice-changing. It's a phase 3 trial with overall survival as primary endpoint that hit all the primary and secondary endpoints. The data are emerging and we are getting longer and longer follow-up, but the data are now very consistent from the Matterhorn trial, Keynote 585, and the Dante trial that I didn't present today, where the early integration, the neoadjuvant integration of anti-PD or PD-L1 inhibitors combined with chemotherapy consistently increases the complete remission rate in the primary tumors when they're resected. Now, we need longer follow-up to see whether this initial increase in response and cure rate of the primary tumor will translate actually in longer survival for the patients. We would take it without radiation. Inducing a complete response means that the disease is controlled everywhere, and we know metastases define the patient's long-term survival. So we are hopeful that with longer follow-up, we will see a benefit and our patients actually living longer with the integration of immune checkpoint inhibitors. So the primary analysis of the Matterhorn trial that was presented showed us that even a limited integration of durvalumab over 8 weeks or 2 doses combined with 4 cycles of FLOT is already able to about triple the rate of complete pathologic response in the tumors that were resected. Now, again, as mentioned, we will see whether that will translate into event-free and overall survival. We take it as a signal that if the patient is tolerating the treatment, especially in tumors that are PD-L1 positive, the integration of durvalumab or other checkpoint inhibitors with chemotherapy, maybe even longer than 8 weeks, might even increase further the rate of patients with complete response. Keynote 585 was a global study, and the majority of the patients actually received a Q3-week regimen of a 5-FU cisplatin or Capox, less so than we would use in the US with the FLOT regimen. Nevertheless, there was a FLOT cohort as well with the safety endpoint, but the key message is that these patients, similar to Matterhorn, underwent about 8 to 9 weeks of preoperative chemotherapy with or without pembrolizumab, now an anti-PD-1 antibody, which was then, after surgery, completed and with pembrolizumab in the treatment arm up to 1 year versus placebo. Very similar to the other studies, we saw a tripling of the complete response rate in the primary tumor, even after only 3 doses of pembrolizumab combined with chemotherapy. Unfortunately, for various reasons, and we don't know all of those, in the all-comer population, that did not translate into an event-free survival benefit. But as I mentioned, the final analysis of the data showed in intent to treat, there was actually numerically higher rate of survival in the patients who received pembrolizumab, but because of statistical reasons, they didn't put a p-value on it. So I think it validates the concept that, especially in CPS PD-L1 positive tumors, addition of a checkpoint inhibitor to chemotherapy will likely improve outcomes. I think the 2 most promising targeted therapies are Claudin 18.2 and FGFR2b overexpression with completed phase 3 trials, Claudin 18.2 monoclonal antibodies, and ongoing phase 3 trials for FGFR2b monoclonal antibodies. And if we take the paradigm of checkpoint inhibitors where we showed their utility in stage 4 and now we're moving them earlier, based on the readout of the stage 4 studies, we will see whether there might be a benefit of moving these targeted therapies in select populations in the earlier line of setting to maybe induce more responses and more survivors of local regional disease. Now, the caveat is when you take a patient for curative intent resection, one of the main messages is do no harm. So we have to certainly establish the safety of integrating these novel biomarkers in the local regional setting. But I think we're all looking forward to the data and the trials that will test these biomarkers in stage 2 and 3.